everyone. The time now is 2 o'clock, and I would like to welcome all of you to Home Nursing Foundation CME webinar series. Today's topic is very timely. It's an update on pharmacological therapy for persons with diabetes, and is being delivered by Dr. Daphne Lee. As there's been many advances in pharmacological treatment in diabetes lately, it will be very helpful for us in the community to be able to be updated in our practice. As you know, Home Nursing Foundation is the largest home healthcare charity in Singapore, providing home-based medical, nursing, therapy, and home personal care to more than 5,000 frail and vulnerable patients each year. We run 2 senior care and community rehab centers at Hougang and Buangkok, and an active aging center to serve the needs of both well and dependent seniors and frail elderly in the community. Under the prolific clinical leadership of Dr. Ng in the last couple of years, we have started this series of continuing professional education since 2022 to raise our understanding and practice of holistic and person-centered care to all our patients and their caregivers to empower them to live joyfully and age well in the community. And over the years, we have covered a wide variety of topics, very pertinent and interesting to community aged care, such as end of life, functional rehab, dementia, falls and osteoporosis, mental health, wound management, and even caregiver support. These many topics are available on the YouTube link in the slides, and please help yourselves to viewing them after the seminar. This afternoon, we are very happy to have Dr. Daphne Lee spend her precious afternoon with us. But before that, I would like to wish all our nurses a very belated Happy Nurses Day, because we did not have our webinar last month. So for this month, I would like to make a special appeal to all of you to support Home Nursing Foundation's efforts in caring for frail elders in the community. As you know, fundraising has been very challenging in the last 1 year, and we have been finding it increasingly difficult to seek public donations. So I would like to appeal to you to support this webinar series by making a small donation, no matter how little. It will go a long way in helping us to uplift the community nurses in caring for the frail and elderly loved ones in the community. Please also scan the QR code if you are prepared to support this series. Thank you very much and have a very good afternoon webinar.
Hi everyone, Stanley here. I'm actually one of the RPs for HNF. So Dr. Ng is usually the one chairing the session, but unfortunately he's not able to be present today. So I'm standing in for today's session. I'm new to this, so please bear with me if there are any boo-boos along the way. We'll try and keep it as smooth as possible. Just some quick housekeeping issues. I think Dr. Daphne will continue with her talk very soon. It should last about 45 minutes at least. There will be a Q&A session after this, so feel free to type your questions into the chat box and we will have her answer as many of the questions as possible, time permitting lah. So it's a very big topic as what Dr. Christina mentioned. Thank you so much. So Dr. Daphne has kindly agreed to give us 2 sessions, one today, where we will talk about the updates on pharmacological therapy. Next month's topic, which is on the 18th of October, it will be on optimizing diabetes care across all life stages. So I think this one is very relevant for a lot of our home care patients in HNF. So may I introduce Dr. Daphne Lee. She's the Medical Director and Consultant Endocrinologist at Dr. Daphne Lee Endocrine and Diabetes Medical Clinic, which is at Mount E, Novena. Her clinical interests include general endocrinology, for example, diabetes mellitus, thyroid disorders, osteoporosis, with her subspecialty interests in adrenal and pituitary conditions. So, Dr. Daphne, the floor is yours. Thank you.
Okay, let me share my slides. Okay, let's see. Okay. Hi, good afternoon, everyone. Thank you, Stanley, for the very kind introduction. My name is Daphne. I'm an endocrinologist in private practice, but prior to starting my own clinic, I was actually in Khoo Teck Puat for many, many years. And today, thanks for the invitation to giving me the opportunity to speak to all of you. And the topic that I've been tasked to talk about is quite a broad topic on updates in therapeutic management for type 2 diabetes. But
Dr.
my
Daphne,
aim,
so sorry. Are you
yeah,
able to switch it to presenter view? The
sorry.
slide view, sorry. Are you
Oh,
able
slide
to
view.
Yeah,
Oh, okay.
thank you.
One moment. So if I use presenter view, you all can see my presenter view, is it?
Yeah, we
Sorry,
can.
slide view.
Oh,
Yeah, we can
okay.
see your presenter view.
Oh, okay. Okay, can. I don't know how to do it without you guys seeing it. Okay, never mind, it's okay. So anyway, so my aims are very simple. I just basically I'm going to focus on some of the latest updates in pharmacological therapies, and these will involve the more modern diabetes treatments, for example, SGLT2 inhibitors and GLP-1 receptor analogs, which I think would be of interest to the audience. And also, I will spend the last few slides summarizing recent guideline recommendations. So I think our understanding of diabetes as well as the therapeutic landscape of diabetes has really evolved tremendously from the early days when I was a house officer to the current to the current times. And this, of course, rises because our understanding of diabetes as a disease has also evolved tremendously. And I thought I'd just spend a little bit of time to just go through this slide. So in the early 1950s, when diabetes first started coming into the forefront, it was a very glucose-centric model. So our focus was, diabetes as mainly predominantly a disease of sugar, sugar-related, glucose-related disease. And so treatment strategies were really very glucose-centric in nature, and they mainly target lowering blood glucose through insulin, insulin itself, or medications that increase insulin production like sulfonylureas. And then along the way, our understanding also evolved, and we started to understand diabetes as a disease not just of insulin production deficits, but also of insulin resistance. And we understood that, improving insulin resistance, reducing hepatic glucose output was also a very important part of managing diabetes. And then in the early 2010s, the understanding has also gotten more nuanced, and we now look at diabetes as more of a heterogeneous disease involving multiple organs. And this term, the ominous octet, was famously coined by a very renowned professor, Professor Di Fronzo, basically, illustrating different pathophysiologic mechanisms beyond just the beta cell, including things like the incretin effect, including things like kidney glucose metabolism. And the strategy when it comes to diabetes management becomes not just about insulin, improving insulin resistance, increasing insulin production, but more of trying to match the right treatment to the right problem. And this is a picture that illustrates the components of this ominous octet. So as I mentioned earlier, there is, besides being very beta cell centric, it also includes pathophysiologic mechanisms outside of the beta cell, like for example, in the brain, in the kidney, in the liver, etc. And our current understanding, has further progressed, right? And now we don't talk about ominous octet, we talk about the egregious 11. And basically, this is an expanded update to the ominous octet to include new insights into additional mechanisms contributing to diabetes as well as disease progression. Right, and it includes, right, in addition to ominous octet, it includes other pathophysiologic mechanisms in relation to the immune system, whether chronic low-grade inflammation drives insulin resistance, beta cell failure. And there's also a lot of interest in gut microbiome research and how this affects metabolism, incretin effects, and inflammation. And another very exciting aspect is relating to ectopic fats, lipid toxicity, and whether excess fat in our liver, muscle, and pancreas actually impairs insulin action and secretion. And, the next frontier will probably take us to the era of individualized therapy based on genetics, right? And now there's a lot of research going on in terms of genetic therapy, gene therapy for diabetes. And we look forward to seeing all this come, into clinical practice in the future. So this slide actually captures the current therapeutic landscape for type 2 diabetes, and it shows basically it's a timeline going all the way back to the early 20th century, all the way to current to the current timeline in 2020s. And it shows how our therapeutic landscape has really evolved from the early days where people were just using insulin to sulfonylureas, to metformin, to thiazolidinediones, to now DPP-4 inhibitors, SGLT2 inhibitors, and GLP-1 receptor agonists. So I think for today's talk, I will be primarily focusing on the more newer kind of type 2 diabetes therapies, which is SGLT2 and GLP-1s. But before I go into that, I thought I'll just have a quick slide just to go through quickly the current OHGAs that we are all very familiar with. So starting with metformin, I would say metformin is still first line in most people with type 2 diabetes, and I think it's a medicine that is very cheap, easily available, and a lot of doctors are very familiar with its use. But increasingly with the era of SGLT2s and GLP-1s coming to the forefront, the treatment choice, especially the initial treatment choice, is increasingly being individualized, with priority being given to the more modern therapies, especially in patients who have established cardiovascular risk factors, cardiovascular disease, heart failure, or chronic kidney disease. And we'll talk a little bit about this later on in the presentation. And by far, the most common side effects with metformin are mostly gastrointestinal in nature, but these can be mitigated with slow titration, that means gentle titration, extended release formulations, or simply asking the patient to take metformin with food. That tends to help with the GI side effects as well. And then sulfonylureas, so things like glipizide, gliclazide, glimepiride, these are very old traditional, medications, and basically they work by stimulating insulin release from your pancreas. I would say in the current day and age, there's still a role for sulfonylureas, although probably much narrower than before. I still find it to be a very useful glycemic, in terms of its glycemic efficacy, I still find it to be very useful. But now with increasing new therapies and with a lot of interest and research in the cardiometabolic space, sulfonylureas, the role for sulfonylureas, I would say, is narrowed, although it can still be useful in some circumstances. And in terms of the main downsides to sulfonylureas, it will be mainly hypoglycemia and weight gain. Right, and so if you want to use the sulfonylurea, you still can, but you may want to consider more modern sulfonylureas like gliclazide over the older ones like glibenclamide, because gliclazide also has demonstrated cardiovascular safety compared to the older generations of SUs. And then perhaps maybe something that is a little bit of an old drug, but may not be so commonly used nowadays, which is thiazolidinediones, and the drug. The drug that is commonly used, this class is Actos or pioglitazone. So because of historical issues with concerns with its safety of this class of medicine, especially in relation to heart failure and certain cancer risks, the use is perhaps not as widespread as, say, like metformin or sulfonylureas, but they are still potentially beneficial in a select group of patients, particularly those who have a NASH, which is what we commonly known as fatty liver disease, and this is not uncommon in diabetic patients as well. And then we have the DPP-4 inhibitors, so things like linagliptin, sitagliptin. These are very, very safe, and they are generally very well tolerated by many patients. And they can be used safely in combination with many of the other oral hypoglycemic agents like metformin, sulfonylureas. And in fact, there's some evidence to show that combination of DPP-4 with SGLT2 inhibitors have shown significant glycemic improvement in Asian populations, right? So yeah, just in a nutshell, there's a quick summary of the commonly used OHGAs. Then we'll talk about the SGLT2 inhibitors, and the ones that commonly used locally will be Jardiance, empagliflozin, and Forxiga, which is dapagliflozin. And so the role of SGLT2 actually is rooted very much in the kidneys. And it turns out that the kidneys actually also play a very important role in glucose control. So in normal individuals, right, we filter about 180 grams of glucose a day. But actually, the amount of glucose that is excreted in the urine is less than 0.5 grams a day. And why is this so? And this is so because there's glucose reabsorption that occurs in the kidneys. And this is mediated through the action of SGLT1 and 2. So SGLT1 and SGLT2, these are basically transporter proteins, right? And they are spread along the kidney proximal tubule. And their main action is basically to actively reabsorb glucose back into the body and to minimize glucose output in the urine. So SGLT1, the SGLTs that are best characterized in humans are SGLT1 and 2. So SGLT1 is found not just in the renal tubules, but also there's some SGLT1 in the intestinal mucosa as well. And it's responsible for about 10% of tubular reabsorption of glucose. A majority of glucose is being absorbed through SGLT2. And these are found in S1, S2 segments of the renal proximal tubule, and they are responsible for majority of the tubular reabsorption of glucose. So it turns out that actually in diabetic patients, SGLT2 expression is also upregulated. And actually this is a double whammy in the sense that, they already have a high level of glucose and they are reabsorbing more glucose, right? And that doesn't help with the hyperglycemia. And so this is where SGLT2 inhibitors really fit in terms of the therapeutic landscape for type 2 diabetes, because SGLT2 inhibitors mainly target, right, the SGLT2 transporter, and by reducing glucose reabsorption, it increases glucose excretion, and that helps to improve hyperglycemia. And that is one of the main mechanisms in which SGLT2 leads to improvement in diabetes control. So the two SGLT2 I think that we are most familiar with is empagliflozin and dapagliflozin, and there are some differences in terms of the pharmacokinetics of both of these drugs, in the sense that empagliflozin is a lot more selective for SGLT2 versus dapagliflozin, and so this will theoretically lead to fewer off-target effects, although there's some suggestion that SGLT1 inhibition in fact may boost GLP1 and contribute to incretin effects, so that may actually turn out to be a good thing rather than something deleterious. But if you compare the efficacy in terms of urine glucose excretion, right, it's much more efficacious with empagliflozin compared to dapagliflozin, but that may also mean that there will be more urinary glucose, more potential genital urinal kind of infections with empagliflozin as compared to dapagliflozin. And also EMPA seems to have a higher propensity for ketone elevation, and this is relevant because of the association of normal glycemic DKA with SGLT2 inhibitor. And so sometimes this is just something that needs to be taken into account when we are prescribing these medicines for patients. Okay, and I think when we talk about SGLT2s, one of the very prominent things that we always talk about are the cardiorenal metabolic benefits. And actually this was rather surreptitious because prior to, just now we talked about pioglitazone, right? So this leads me to tell the story of rosiglitazone. So rosiglitazone is a thiazolinidione. It was actually I think launched in the maybe late 1990s, early 2000s, if I'm not wrong. It may be earlier than that, but it was something that came out after metformin, sulfonylurea. So it was touted to be very good, very effective, very good for sugar lowering, etc., etc. But then it turns out that rosiglitazone was increases of there was some concern with regard to cardiovascular safety, and because of that, it was taken off the market. And after rosiglitazone, the FDA in the US actually mandated that any new diabetic drug that's going to be launched, right, have to demonstrate cardiovascular safety. And that's how the era of all these cardiovascular outcome trials came about, especially for diabetic medications, and that was because of rosiglitazone. But surreptitiously, actually, when they were wanting to launch empagliflozin and they did the cardiovascular safety trial, it turned out that actually this was the first diabetic medication to actually demonstrate cardiovascular benefits. And this was unprecedented at that time. So it was the EMPA-REG outcome trial, which I think a lot of you may have heard of. Was truly really a very groundbreaking landmark trial when it comes to the therapeutic landscape for diabetes lah. So this was a large trial, 7,000 patients spread across 42 countries, and basically they tested empagliflozin, the two doses of empagliflozin 10 and 25 mg versus placebo over a median observation time of about 3.1 years. And they were examining basically cardiovascular events because this was a cardiovascular safety trial, right? So the main outcome was a 3-point composite of cardiovascular death, non-fatal MI, and non-fatal stroke. And then there were also some secondary outcomes that they looked at, including all-cause mortality, hospitalization for heart failure, and some renal outcomes as well. So very clearly, the empagliflozin, when compared to placebo, demonstrated a significant reduction in terms of primary outcome for the three-point composite, and also for individual components of these 3-point MACE, including death from cardiovascular causes, and this was primarily driven by death from any causes was primarily driven from benefit in terms of cardiovascular death. And what was very interesting in this case was that actually, if you look at the reduction in cardiovascular death and for heart failure, there was early separation of the curves. So this means that actually, by day 59, if you give a patient empagliflozin, they'll have demonstrated benefits to them already in terms of reduction of cardiovascular death. And this was, and similarly with heart failure as well, hospitalization heart failure, there was a very early separation of the curves. And in fact, at day 17, there was already a benefit demonstrated. So this is basically definitely too early, right? In a sense that if you want to theorize about why these medicines actually lead to such fantastic cardiovascular benefits, is it because of improves the atherosclerotic process? But what we're seeing is that it's too early, right? As in the benefits are occurring too early. So to atherosclerotic process probably take long time to change. So for the drugs to benefit, to demonstrate benefits so early on, it's probably due to some hemodynamic kind of improvement in terms of cardiac contractility and etc. This really goes beyond it being just a diabetic medication. And so this was really something that was really quite astounding at that time when it first came out. And then we have DECLARE-TIMI. So DECLARE-TIMI is actually involve dapagliflozin. And you may be aware that actually in the DECLARE-TIMI trial, there was no, it did not demonstrate any benefits in terms of the 3-point MACE, but it did show significant reduction in hospitalization and death from heart failure. We think that the results are a little bit different because the study population is quite different lah. So in DECLARE-TIMI, is a much larger trial involving, I think, 17,000 patients, if I recall correctly. And they had a lot more patients who were more in a more like a primary prevention kind of cohort. So they did not have established cardiovascular disease. I mean, a portion of them who have established cardiovascular disease, but there was also a large proportion of patients, like about more than 50% of the patients in this study cohort actually did not have cardiovascular disease, but they did have risk factors like dyslipidemia, hypertension, smoking, etc. Yeah, so there was no significant difference in MACE and death, but there was significant reduction in cardiovascular death and hospitalization for heart failure, predominantly driven by reductions in hospitalization for heart failure. So that kinds of sums up a little bit of a difference in terms of the trial outcomes for empagliflozin and dapagliflozin. And when we manage diabetes, the other thing that we are very interested in is also renal outcomes. So there were the EMPA kidney trial was an extension, or actually not extension, it was a dedicated trial looking at renal outcomes. And again, empagliflozin showed that it significantly reduced the risk of CKD progression and cardiovascular death in CKD patients, and the risk reduction was in the magnitude of about 28%. And this seems to be a class effect because these benefits on the beneficial outcomes on renal indices was actually demonstrated across multiple trials involving SGLT2 inhibitors. For example, the CREDENCE trial, which was a trial with canagliflozin, which we don't use here in Singapore anymore, but It also did demonstrate very good renal outcomes. And then DAPA-CKD, which was basically involving dapagliflozin in CKD patients, also demonstrated very good significant benefits in terms of renal outcomes for the study population. And this is regardless of diabetes status. So SGLT2 inhibitors reduces risk of kidney progression across a broad range of populations, and whether they have diabetes-related kidney disease or chronic kidney disease due to other causes. SGLT2 does demonstrate significant benefits for the kidneys. And so much so that now SGLT2s are in fact indicated as first-line therapy in addition to RAS inhibitors, in addition to, managing glycemic control, statin therapy, etc., for diabetic kidney disease, and in fact for chronic kidney disease as well. And SGLT2 inhibitors can be initiated with an eGFR as low as 20, especially for empagliflozin, and up to 25, right, for dapagliflozin. And once they're initiated, they can actually continue it throughout dialysis, except canagliflozin. But nowadays, we hardly use canagliflozin anymore. So if the patient is diabetic, or has other very established cardiovascular disease, then we would strongly encourage consideration early on of using SGLT2 inhibitors up to eGFR about 20-25. Okay, then all the good benefits aside, right? What are the safety concerns and what are some of the risks of SGLT2 inhibitors? So this slide kind of summarizes the adverse events that are have been associated with SGLT2 inhibitors. So as I mentioned, genital urinary infections are not uncommon. It can range from mild infections to severe infections like pyelonephritis or Fournier's gangrene for that matter. So this is something that we always warn patients about. And when it comes to patient selection, right, if patients are at risk of UTIs, they are bed-bound, etc., you may want to be careful about starting SGLT2 or at least monitor it very closely. Then there were some safety concerns in relation to bone fractures and amputation in lower limbs, especially with canagliflozin. And that's also one of the reasons why that is seldom being used nowadays, at least not locally. Then I alluded to normal glycemic ketoacidosis. So this is something that is rare, but has happened before, and I'll talk a little bit about it later on. And as with any diabetic medication, there's always a risk of hypoglycemia, particularly if you use SGLT2 in combination with other OHGAs or with with insulin, right? And there's also a BP lowering effect, maybe because of the diuretic effect of SGLT2s. And so hypotension is something that we need to look out for, right? And if the patient is also on a diuretic or maybe on a blood pressure lowering medication, when you start at SGLT2, you may want to review those things and see whether the doses can be reduced. But in any case, you need to monitor the blood pressure, the blood sugars quite closely. Okay, so coming to euglycemic DKA, so this is something that has been described and associated with SGLT2 inhibitors. And how do we prevent or how do we, mitigate this risk of a patient having developing euglycemic DKA or SGLT2? I think it boils down to a couple of things. Firstly, patient selection. So definitely avoid in patients with type 1 diabetes, right? Because they are already, by nature of the pathophysiology of the disease, prone to getting ketoacidosis. So SGLT2s are not recommended to be used in type 1 diabetes. And in patients who are on insulin or those who are on ketogenic diets or frequent fasting, like for example, our Malay patients who maybe are fasting for Ramadan, right? You may need to basically preempt them and or use it with caution, or maybe you may need to adjust the dose or reduce it during that or stop it during that period of time. And when you initiate SGLT2 inhibitors in a patient already treated with insulin, right? Just be a little bit careful not to suddenly reduce the insulin dose by a lot, because that will disrupt the balance between insulin and in ketosis, and that can sometimes lead to euglycemic DKA as well. And then, of course, education is very important, right? Educating our patients about DKA symptoms and to stress to them that this can happen even if their sugars are normal, right? And also educating them to avoid very low-carb ketogenic diets, which can also predispose to ketosis. And then lastly, but very important to emphasize to them what to do in times of illness lah. So sick day rules. So we would generally advise during acute illness, especially if there's vomiting, there's dehydration, reduced oral intake, or even perioperatively, we would hold the SGLT2s. And there are many guidelines actually recommend stopping SGLT2s 3 days before an elective surgery. And if they're unwell, right, and if they're on an SGLT2, or say they're fasting, etc., they may want to check their blood ketones in addition to just checking a blood glucose. So you can buy ketone strips from the pharmacy, and it's basically you check your blood ketones in the same way you would check a hypo count. And that will give you a indicator of whether there's any ketosis present or not. And of course, if there are symptoms, the patient is unwell, they're not sure what to do, always seek an early medical review. So some advice that we give to patients when they are on SGLT2s would be, firstly, we try to encourage them, if it's not contraindicated, to increase their fluid intake. That will help to reduce the risk of having UTIs. Important to practice good genital hygiene, right? So in men, we advise them to, they have to retract their foreskin, clean the area regularly and stuff like that. Ask them not to hold in their urine. So if they need to go, please go, right? That all these will help to reduce the risk of UTIs, and to avoid having ketogenic diets or excessive alcohol intake. And also to counsel them, right, about some of the effects of SGLT2s, and it can cause more polyuria. It can cause weight loss, not in the magnitude that we see with GLP-1s, but I've seen some patients lose 5 to 10 kilos on SGLT2. So sometimes it's good to preempt them. If not, they'll get very worried. And then also, as I mentioned, SGLT2s also do have some mild blood pressure lowering effects. So you may want to warn your patients or review their blood pressure medications. And if they are experiencing severe diarrhea, vomiting, or if it's within 72 hours before surgery, to stop the SGLT2, and again to seek medical advice if the patient experiences the following symptoms. Okay, so that's kind of sums up my section on SGLT2 inhibitors. I'll move on to talk about GLP-1 receptor analogs. So what is GLP-1? GLP-1 actually is a hormone that's produced by our intestines, and it stimulates insulin secretion postprandially. So it helps to lower your blood sugar level after meals, and this is what we know as the incretin effects. So there's GLP-1 and there's GIP. So these are the two incretins that are known in humans, right, and are frequently targets for therapeutics as well. So again, as with SGLT2 upregulations, the incretin effect actually has been demonstrated to be in fact reduced in type 2 diabetics. And this has led to ideas for development of incretin-based therapy. And basically there are two strategies, right? Because GLP-1 is broken down by DPP-4. By inhibiting DPP-4, you can prevent degradation of native GLP and enhance the incretin effect. So this is how things like sitagliptin and linagliptin will work. The other strategy would be to increase GLP-1 concentrations by activating the GLP receptor, and this is how your GLP-1 like semaglutide, tirzepatide would work. And the benefits of incretin-based therapy is that actually very low incidence of hypoglycemia. Because the insulin release is triggered only usually with meals. So the action of incretin-based therapy are mostly in the postprandial phase. So really we don't expect to see a lot of hypoglycemia with this class of therapies. But the challenges, especially in the early days when we were developing this therapy, was that the GLP-1 short life is very, very short. And it gets rapidly degraded by DPP-4, and that's why it cannot be taken orally. And in fact, the early versions of GLP-1s actually involve frequent injections per day. So again, the breakthrough in terms of GLP-1 occurred rather surreptitiously as well. And the very first GLP-1 that was being released back in 2005 was exenatide. And this was actually being made from I think the saliva of the Gila monster was found to contain, homologous GLP-1. And so that was way back in 2005. So actually, GLP-1s is not just a recent thing. It's been around the market for 20 years really. But the early GLP-1s have very short half-life, so they had to be injected daily and sometimes several times a day as well. And then the breakthrough came in about 2009, right? Not 2009, 2019, like 14 years later, with the release of semaglutide. And there are 3 formulations of semaglutide, right? So there's the oral one, which is Rybelsus, and that's the only oral GLP-1 that's available out in the market. It comes in 3 strengths, 3 mg, 7 mg, and 14 mg. And then you have Ozempic, which is essentially semaglutide as well, but is given as a subcutaneous injection once a week. And it is formulated, there are 3 formulations of Ozempic: 0.25 mg, 0.5 mg, and 1 mg. And they have 2 mg in the US, but that's not available here in Singapore. And recently, in July, the Novo Nordisk has launched Wegovy, right? So Wegovy also is actually similar to Ozempic, just that it's indicated for obesity, whereas Ozempic is indicated for diabetes. So being indicated for obesity, Wegovy can actually go all the way up to 2.4 mg. So there are 5 different strengths of Wegovy. And then most recently, we have tirzepatide, which is Mounjaro, and this was being launched actually just two weeks ago at the end of August. So semaglutide is mainly a GLP-1 receptor analog, right? Whereas tirzepatide is a dual agonist. So just like I mentioned, there are 2 incretins, right? GLP-1 and GIP. So tirzepatide actually it hits both GIP and GLP, whereas semaglutide is actually just GLP-1. So similar to semaglutide, tirzepatide is given as a once-a-week subcutaneous injection. There are also 5 to 6 formulations starting from 2.5, and it goes up in increments of 2.5 all the way up to 15 mg. There are 2 brands, of which only Mounjaro is available in Singapore. The other version is Zepbound, and that is not being launched in Singapore. And Zepbound actually they both are the same thing lah. They are actually both tirzepatide, but because of regulatory approvals, is being branded, one for diabetes and one for obesity is in the US, and so that's why they have this name. But essentially, it's the same thing. The content is the same, the dose strength, everything, administration, everything is the same. So for all intents and purposes, it's basically tirzepatide. Okay. Then I thought let's share a little bit about semaglutide and tirzepatide, because these are the ones that are created. That everybody is talking about, especially in the last 5 years or so. So how do they perform in terms of glycemic efficacy, in terms of weight loss, in terms of cardio-renal metabolic protection? So this slide actually shows a snapshot of the glycemic efficacy of semaglutide 1 mg, which is Ozempic. And the series of trials that examine this were called the SUSTAIN trials. So basically, SUSTAIN 1 all the way to SUSTAIN 6. And basically, they are comparing semaglutide with various different types of diabetes treatment, from sitagliptin, from insulin, versus metformin. And I think you can see clearly that the blue bars, the light blue and the dark blue bars, represent semaglutide, and I think it's quite clearly demonstrated that when in comparison with either placebo or conventional treatment, semaglutide 1 mg actually does have superior HbA1c lowering efficacy. Same for oral semaglutide. So this is Rybelsus. So in the pioneer trials, again, they demonstrated superior HbA1c lowering when compared with, say, SGLT2 inhibitors, DPP4s, insulin, etc. SURPASS is basically looking at tirzepatide, right? So Mounjaro. So SURPASS trials again also demonstrate, very good glycemic efficacy when compared to conventional treatment like metformin, insulin, SUs, SGLT2 inhibitors, etc. So I think in terms of glycemic efficacy, there's no argument lah. They are definitely effective, and glucose control still remains one of the key targets for diabetes management, and it's definitely made a big contribution in terms of therapeutics for diabetic patients. And then what is of interest, to us is also the obesity and weight loss aspect of things. And I think in my practice, at least, a lot of diabetic patients do come with weight concerns as well. And in the past, the earlier generations of GLP-1s like Victoza, like Saxenda, they do demonstrate some weight loss benefits, but not to the magnitude of what we are seeing now with Ozempic and Mounjaro and Wegovy. And of course, weight loss does help diabetes itself as well. And even the patient is not diabetic, but they're overweight, that actually does put them at risk of a lot of cardiometabolic complications. And so, this is definitely something of interest to me as endocrinologist. So the mechanisms in just now we talked about how GLP-1 lowers blood sugar, right? So how GLP-1 helps with the weight is mainly by two mechanisms. One is that it basically delays gastric emptying. So it slows down the rate of digestion, so you feel full for a longer period of time and you feel full much earlier, and that leads you to eat less, essentially. What is also very important in terms of the mechanism is it basically affects the crosstalk between your brain and your gut, right? So it enhances the satiety signaling and downplays the hunger signal. So a lot of patients tell me that it reduces the food noise. They don't think about food so much. Even if they feel hungry, actually they eat a little bit, they are full already because it increases the satiety signals. And I think these two in combination actually results in the significant weight loss that we are seeing with this class of medications. So again, going back to the SUSTAIN trial, so when they were looking at, not just HbA1c efficacy lowering, when they observe the weight loss effects of this medicine, they noticed that, actually this semaglutide is actually, resulting in quite a bit of weight loss, right, compared to your conventional treatment and compared to earlier weight loss medications. And even when you compare semaglutide with earlier, versions of GLP-1s like dulaglutide, like liraglutide, the weight loss is definitely superior as well. I mean, not all these are head-to-head trials, but in some of the head-to-head trials, like when they look at, for example, in this red bar here, semaglutide compared with liraglutide, there's definitely superiority, right? Again, if you compare semaglutide 1 mg, which is Ozempic, with exenatide, which is very, very early version of GLP-1, again, there's clearly demonstrated superior efficacy when it comes to weight loss. So what about Wegovy, which is 2.4 mg, and Wegovy is being marketed as targeted for obesity patients. So again, you see, we do see across the board, right, significant amount of weight reduction in the magnitude of about 10 to 15%, sometimes close to 20%, of course, over a period of time. But what's interesting also is that diabetes seems to attenuate weight loss. So when they give semaglutide 2.4 mg to patients who are diabetic and overweight, they do lose weight, but the amount of weight that they lose seems to be attenuated compared to the patients who are non-diabetic, right? SURMOUNT were the trials that were examining tirzepatide in obesity. Again, you see very good weight reduction. In fact, the magnitude, again, not head-to-head, but the magnitude of weight loss you tend to observe in tirzepatide tends to be higher, up to about 15, 20, sometimes 25%. And again, this also the SURMOUNT trials also demonstrate that there seems to be a smaller effect in diabetic patients. Okay, and then the latest thing to come out is SURMOUNT-5. So SURMOUNT-5 actually compares directly tirzepatide versus semaglutide 2.4, which is Wegovy. And it's a phase 3 randomized control trial, basically in obese patients with weight-related comorbidities, but excluding diabetic patients. And there seems to be a superior effect with tirzepatide compared with semaglutide, both in terms of the magnitude of weight lowering and in terms of other, weight-related parameters like change in weight circumference, etc. And more patients seem to hold on to their weight loss in the tirzepatide group compared to semaglutide group. So there seems to be some superiority there. Okay, then the last part about GLP-1s in regard to the trial data would be on cardiovascular and renal outcomes. So again, there has been a lot of, interest in the cardiovascular safety of GLP-1s. And because they were launched after rosiglitazone era, so they also had to demonstrate cardiovascular safety, and that's how these cardiovascular outcome trials came about. So in SUSTAIN-6, right, they basically looked at patients with diabetes, right, and then they give them semaglutide up to 1 mg, and it basically demonstrated superior significant lowering in terms of the MACE outcome, up to 26%, right, and this was also demonstrated in the oral version of semaglutide in the PIONEER-6 trial, with a magnitude of risk reduction of about 21%. right? So they further on went on to actually examine semaglutide oral in a dedicated cardiovascular outcome trial, because earlier Pioneer 6 was just meant to demonstrate safety but not meant to demonstrate superiority. So there was actually a dedicated trial for semaglutide, oral semaglutide, looking at cardiovascular outcomes lah. So again, I think you can see that there's definitely the semaglutide definitely clearly demonstrates improvement in multiple events, right, including the primary outcome, which was a MACE composite of CV death, non-fatal MI, the usual 3-point MACE, and there has been a significant efficacy. And I think there also was some suggestion that there's also early separation of the curves as well, although I don't have the data on that, but yeah. And then what about Wegovy, right? What about non-diabetic patients who are maybe obese, right? Do they also benefit from, do they also have all these cardiovascular benefits? So the STEP trials, right? Sorry, not STEP trial, this is the SELECT trial. The SELECT trial actually looked at the semaglutide 2.4, which is the dose that we use for obese patients on a group of obese patients with cardiovascular risk, and it was demonstrated, the primary outcome was positive lah. So there was a 20% relative risk reduction in the MACE-3 events. However, the secondary outcomes did not all demonstrate statistical significance, even though there was a trend towards benefit. But still, there was a risk reduction in terms of the 3-point MACE, and particularly for non-fatal MIs. Right. Then how about renal outcomes, right? Because renal outcomes also something we are very interested in. So are they, also equally as efficacious as SGLT2 inhibitors? Are they equally useful for patients with CKD and diabetes? So this is a FLOW trial. Again, another landmark trial, double-blinded, placebo-controlled, randomized control trial in patients with diabetes and CKD. The major outcomes that they were looking at were basically kidney failure, reduction in eGFR, death from kidney-related disease or cardiovascular disease. And again, semaglutide has demonstrated a significant risk reduction in terms of renal benefits in diabetic patients. And the benefits were in clinically important outcomes like kidney failure, reduction in death from cardiovascular disease as well. What about tirzepatide? So tirzepatide, the CVOT trial, I think, is currently being presented at EASD in September. The peer review article will probably come out sometime NEJM this month. But based on the earlier trials that were done in the SURPASS trial, which were basically looking at tirzepatide's glycemic efficacy, there were hints of benefit. There were definitely signs of benefits in terms of using tirzepatide in diabetic patients and reduction in cardiovascular risk and kidney function as well. So we are awaiting the subsequent dedicated trials for these yeah. So hopefully, by this month we'll get some update on CVOT for tirzepatide. So I think if I were to summarize, the key takeaways for all the things that we have talked about in the previous slides, I think GLP-1 therapy has definitely demonstrated improvement in glycemia, weight, CV, and renal cardiovascular and renal outcomes. For semaglutide, there is strong evidence for benefit in type 2 diabetes, obesity, cardiovascular, and renal disease. For tirzepatide, it gives the highest amount of weight loss and HbA1c reduction. There's still ongoing CVOT and CKD trials, so we are awaiting the results. But in general, both therapies have actually redefined, cardio-renal metabolic management in diabetes as well as obesity. Okay, then after talking about all the benefits, of course, we need to look at the safety and adverse events. So I think the most common adverse event in GLP-1 therapy is really nausea and gastrointestinal side effects. They tend to be dose-dependent and also time-dependent. So the good news is that usually, right, as time progresses, if the patient is able to tolerate, right, the doses, the nausea actually gets better. And this is also the reason why when we start a GLP-1 in a naive patient, right, we usually start at a low dose and we slowly escalate the therapy. So we start at like the lowest dose for a month, then after we escalate to the second level dose for another month, and then we do it gradually. So we don't, right from the get-go give like a high dose or medium dose to the patient. This is to help to mitigate the side effects lah, especially in regards to nausea and constipation, gastrointestinal related side effects. These are some of the other potential concerns when it comes to GLP-1 receptor agonists. So as I mentioned, gastrointestinal side effects. Some patients lose a lot of weight, especially with Mounjaro, and that can lead to some facial concerns like, sagging of the skin. I have one patient go for a facelift because of the weight loss. But yeah. So, and then, of course, glycemic considerations as well, because it's still a glycemic lowering agent. So especially when you combine it with other medications, you need to look out for hypoglycemia, right? There's also some association with pancreatitis, right? And cholelithiasis, particularly if there's rapid weight loss. So if the patient got severe tummy pain or high fever, that kind of thing, then and they're on GLP-1, then we need to think of pancreatitis. Some other things that are relevant would be the risk of thyroid cancer, particularly medullary thyroid cancer. So this was association found in animal studies, in rodent studies. In the years that GLP-1s have been used, if you go all the way back to 2005, exenatide, all the way now, there hasn't been any hint of this translating to humans as well. But with cancer, sometimes we never know lah, because these are all very young drugs to begin with. So if the patient has family history of medullary thyroid cancer, which is actually a very rare cancer to begin with, but it can be associated with certain things like multiple endocrine neoplasia. So there's some signal there in the family history. We'll be very careful about using this class of medications. Okay, so this is a little bit of a busy slide, but basically it illustrates give some tips as to how to manage some of the adverse reactions to GLP-1s. So always start low, go slow, escalate gradually, right? And of course, there's some flexibility in the escalation lah. So for individual tolerance, so if the patient wants to take things a little slow, if they want to titrate over 2 months instead of 1, is perfectly fine as well. I generally allow them to titrate over a longer period rather than over a shorter period, right? Then of course, always keep in touch with your patients and, always look out for side effects, ask them to get in touch with you. So I find that increasing hydration helps, right? Particularly when it comes to constipation, getting them to take small meals, right? Not overeating, listen to their body signals. If their body is telling them they're full, don't overeat, because that tends to actually, perpetuate the GI side effects. Sometimes short-term symptomatic management helps, like antiemetics or proton pump inhibitors. If really cannot, we can de-escalate the dose. So let's say if they're on a 1 mg and they get bad side effects, right, we can de-escalate to 0.5 of semaglutide and then take it from there. If really cannot, then of course we have to stop therapy lah, right, and consider any alternative kind of management for either the diabetes or obesity. Sometimes I find switching to an alternate GLP-1 helps. So like if the patient has intolerable side effects to say Wegovy, switching to Mounjaro does help to mitigate some of this, because the GI side effects seem to be lesser with Mounjaro compared to Wegovy. Yeah, and the other thing that patients are always very concerned with is like, doctor, how long do I have to be on these medications? What's going to happen if I stop the medication? Is my weight going to come back? So the short answer is yes. If you were to stop treatment, right, weight comes back, and this has been demonstrated in various trials as well. And patients may regain up to 50% of whatever they have lost. So I always tell my patients, this is not a magic bullet lah, right, when it comes to weight loss. So you need to actually work on the other important aspects as well when it comes to diabetes, especially when it comes to diet, when it comes to exercise. And also importantly, when you lose weight, you're actually also losing fat. You're not just losing fat mass, you're also losing some muscle mass. And that can raise concerns of, having like sarcopenia and stuff like that. So I tell them it's very important that you still maintain an exercise regime to tone up your muscles and to minimize that muscle loss lah. So I tell my patients, usually if they're taking it for weight, like BMI 40, they're taking it for weight management, they don't want to go for bariatric surgery, that kind of thing, right? I tell them you give it a year. a year to a year and a half to basically maximize the effects of the medication. After that, right, if you want to try to cut, if you want to stop, do not stop it abruptly. We can try to down titrate the dose, right? So that means, like, just as we escalate up the dose to optimal dose, we can try and down titrate and then try and see if we can maintain at a lower dose. I mean, all these are really uncharted territory lah. So this is not evidence-based or guideline-based, but it's something that I find that is logical and safe. So yeah, so just kind of sharing some experience when it comes to GLP-1 therapy and with regard to this particular issue of weight regain. So the last 5 minutes, I just want to spend talking about the latest guidelines in diabetes. This is the 2025 ADA guidelines, and a lot of us take reference from this when it comes to the therapeutic management of diabetes. So I think when it comes to diabetes management, first line is still always healthy lifestyle behaviors, right? Having good education, good support. Then we assess the patients. So now it's no longer like a straight everybody metformin first line, but it's very individualized, right? So if the patient has high cardiovascular risk, high kidney disease risk, and type 2 diabetes, or they need to lose weight, let's say they are diabetic and BMI is in the obesity range or even in the overweight range, then we will select therapies accordingly. So if the patient has high cardiovascular risk, you would want to go for GLP-1 with a proven cardiovascular benefit, like for example, semaglutide, or an SGLT2 with proven cardiovascular benefit, for example, empagliflozin, right? So you can consider this first line as well, is based on the guidelines. So if the patient has heart failure, or if the patient has either heart failure preserved EF or reduced EF, right? We want to consider SGLT2 preferentially because of its proven benefits in this population. The patient has pre-existing CKD already, right, or DKD, right? Then consider SGLT2 definitely, right, because it has very strong evidence of reducing CKD progression, or even a GLP-1, like for example semaglutide, which has proven CKD benefit. And of course, if HbA1c is still above goal, you can actually, add on additional agents. So if the patient's on SGLT2, you can consider adding a GLP-1. This combination is safe. If it's on an SGLT2, maybe you can add on and vice versa. So GLP-1, you can add on SGLT2. Then subsequently, you can add on metformin, you can add on your dimicron, right? Important to avoid therapeutic inertia, to reassess and modify treatment regularly. So if the patient needs to lose weight, right, the guidelines actually gives a nice table in terms of, what are the medicines, what are the drugs with the highest efficacy for weight loss. So that would be semaglutide, tirzepatide, and then the, high to intermediate would be other GLP-1s like liraglutide, like Saxenda, or dulaglutide, which is Trulicity, right? And then the ones that are more or less weight neutral would be metformin, DPP-4, and then you have those that cause weight gain. So like sulfonylureas or insulin. So if your patient is someone who needs to lose weight, you may want to consider some other medications as compared to, say, a SU. So the goal ultimately is to achieve and to maintain HbA1c less than 7%, right? And whichever agent you start with first, right? You always monitor, titrate, and escalate therapy as required. So the difference between 2025 and previous years in terms of the guidelines is that there is now an emphasis on earlier use of SGLT2 inhibitors and GLP-1s, especially patients who are at risk, even before metformin, if it's indicated. I mean, previous years, metformin, as I said, metformin usually first line default, right, for all patients. And then GLP-1s and SGLT2 were only recommended if the patient not achieving glycemic targets or if they establish CVD. But I think now there is an emphasis on using these drugs earlier on in the treatment algorithm. Prioritizing cardio and renal vascular outcomes, right, to choose therapy guided by comorbidities, right, whereas in the previous years, focus was primarily on glycemic control. And then individualized therapy, consider weight, consider hypoglycemic risk, consider preferences and costs. And I think one of the things that the guidelines highlight is to consider using combination therapy earlier, And we should consider doing using dual or triple therapy upfront if the HbA1c is significantly above target, or especially if the patient has comorbidities, rather than go by a stepwise approach, starting at one drug and then you add others sequentially. And insulin use is still advocated, but generally reserved for those who suffer hyperglycemia. For example, those that come with HbA1c more than 10, patients who are very symptomatic with signs of glucose toxicity, or if they fail, GLP-1 therapy. And then the one thing I didn't cover here today is about technology. So there's been a lot of advances in terms of diabetes technology, in terms of CGMS and digital monitoring. And they are now being increasingly recommended for type 2 patients as well, not just for type 1 patients. And we can talk about this maybe in the next lecture. So some practical takeaways, right, from the guidelines would be personalized therapy, right? Don't just look at HbA1c, look at the comorbidities, use cardiorenal protective agents earlier, right? Address weight proactively. Right now, there are very good anti-obesity weight management medications in addition to having structured lifestyle interventions. We should emphasize them more strongly as well. If the patient is overweight or obese, right, definitely consider a GLP-1 receptor agonist wherever it's accessible. And then individualized glycemic targets remain a standard, with tighter targets for lower risk patients and more relaxed targets for patients who are more frail. So I know it's a very long talk, it's a very dry topic, but just some take-home messages before I end. So I think in terms of the therapeutic landscape for diabetes, it has really evolved a lot. And I remember the early days when I was a house officer, a medical student, we only had metformin, glycemic, and then acarbose, right? And then later on we had rosiglitazone, but then that was taken off. And then for a long time, we did have a lot of very good medications until SGLT2 came along, DPP4, GLP-1. So it's good for our patients that there's a lot of pharmaceutical interest in this, and hopefully more and more better drugs come out in the future, right? I think the key pharmacological advances in terms of therapeutic management would be to prioritize SGLT2 inhibitors and GLP-1s much earlier in the treatment. And especially for those who have established cardiovascular disease, heart failure, or CKD, and including those who are obese. Metformin still remains first line for most, but like I said, treatment is increasingly being personalized based on comorbidities and patient factors. So that's the end of my talk. Right. Thank you for your kind attention. I'm happy to take any questions if there are any.
Thank you so much, Dr. Daphne. That's a lot of information. We are so grateful. I think we will, let's clear the question on the SGLT2 inhibitors. I think this is something, this question is also something very close to our home medical patients. This is something quite relevant for us, especially with regards to the risk of genital urinary infections. So a lot of our patients in home care are frail, bedbound, on IDCs, recurrent UTIs or CORTIs. Would you classify this group of patients to be really contraindicated against SGLT2 inhibitors? And do you have any other additional groups of patients which you would avoid this in them? And can I extend this question further? If I were to start SGLT2 inhibitors for my elderly patients and they were to get UTIs, do you have any advice, for example, on like the threshold, on the frequency or severity of UTIs before we say, hey, it's time to stop the EMPA?
Yeah, so I think yeah, it's very true. I mean, the population that you guys tend to see, a lot, some of them are very frail, they are bedbound, they are on long-term IDC. I think these do constitute risk. I'll be careful about starting SGLT2 in these patients. Patients who have a history of recurrent UTIs, definitely I would be very hesitant to start as well. If the patient has a UTI, if it's just a mild UTI, I may, and the patient is, say you start SGLT2, develop a mild UTI, can be treated with antibiotics, it gets better. I may still consider continuing, especially if there is a strong reason to do so, like patient got, chronic kidney disease or cardiovascular disease. But if, let's say, the UTI frequency, I mean, there's no magic number lah, but I think if, let's say, they are getting like, 3 3 times a year, 4 times a year kind of thing. And, you know, it ends up in a hospitalization. It develops into like a multi-drug resistant kind of thing. Then I would probably, no choice, stop the SGLT2 and then use other alternatives to manage their diabetes, and to manage their CKD and heart failure and stuff like that lah. Yeah. So yeah.
Okay.
Mm,
Clinically directed lah,
yeah.
Ken, with regards to, I think the next few questions are on GLP-1 receptor agonists. I think there's
Yeah.
one recommended duration on the treatment of the semaglutide for weight loss. I think you've answered that.
Yeah.
Let's move on. Oral versus injectable semaglutide. Any efficacy difference between the two? Price differences? When would you choose which one? And also, I think there is this question about the psychiatric adverse effects of GLP-1 receptor agonists.
Yeah. So, with regard to the first question, oral versus injections, if possible, I would usually try to I would prefer injections. I mean, the trial data, right, if you compare, right, actually the efficacy is supposed to be the same, whether you use oral or whether you use subcutaneous. But I do find in real life, there's some difference, and I find patients tend to have better result and faster result with injections compared to oral GLP-1s. But oral GLP-1s are slightly more cost effective when compared to the injections. So I mean, the price difference is not huge lah. It's not like, magnitude of few $100s kind of thing, but there is still a little bit of a difference. So it depends on patients' choice, right? Depends on, some of them really cannot, not comfortable with injections, and so they go for orals. They will still lose weight, I would say. They will still have glycemic improvement. They will still have benefits. But if you're in terms of, if you ask me the speed and the magnitude, I would say injections will probably have a slight edge, but this is my take on it, my 2 cents worth. It's not evidence-based or anything like that. Then the second question is with regard to psychiatric adverse effects, right? Yeah. So there have been some case reports of people having depression, mood disturbances, suicide even, with GLP-1s. I think it's an association that has to be explored a bit more deeply. We do not know whether this is direct cause and effect, or what exactly is causing these observations. But I would be careful if my patients are depressed, they're on antidepressants, they're seeing a psychiatrist. And if they come to me asking for GLP-1s, I would definitely be upfront about this with them. I would probably check in with their psychiatrist to make sure that they are okay. Like if they are stable, like they're not in active depression, or have high suicidal risk kind of thing, then those have to be very, very, very careful. But if they are stable, they are on treatment, they are, the psychiatrist is come. Sometimes the psychiatrist send them to me, but so I think we do not know whether is it cause and effect, or is it just association, whether is it something something really that we need to take note of. But as of now, it's not really come to a point that we don't give patients because of their history of psychiatric illness lah. In fact, there's also research going on as GLP-1s in things like dementia, mental illness, right? And there may be some benefits in other kind of mental disorders. Yeah. So yeah, need to keep a lookout for that space.
Thank you. We have gone past the 3 o'clock mark. Maybe just one last question. Are there head-to-head trials comparing GLP-1 agonists versus bariatric surgery for weight loss in obese patients?
I think so far no, but I would imagine someone might do something like that. I mean, I not to my knowledge lah. I don't think there are any head-to-head trials comparing bariatric surgery and GLP-1s. But yeah, maybe in the future there might be one. It looks like a topic that's worth exploring, and I think there will be eventually a study that's done on this. Yeah.
Thank you so much,
Mm.
Dr. Daphne.
Mm.
See you next month, everyone,
Okay.
for part 2 of the talk, where we will look at DM management across life stages. Dr. Christina, do you have any last words?
No, except have a very good weekend and see you next month. Thanks, Daphne.
Thank you. Thank you. Bye-bye.
Bye bye, everyone.
Bye.